So today we are going to start about growth hormone. This growth hormone is produced from pituitary and from the anterior part, and it is 50% of the anterior pituitary is made of somatotrophs. What are somatotrophs? Somatotrophs are acidophilic in nature. So what are the factors regulating growth hormone? What are the factors? Factors which are increasing growth hormone are GHRH, ghrelin, then hypoglycemia, and non-REM 3 and 4 phase of sleep. So growth hormone is increasing by GHRH released from hypothalamus. Ghrelin released from GI system, and hypoglycemia and non-REM sleep. So the factors which are decreasing are, what will it be? Hypoglycemia, so hyperglycemia. Obesity. And with the increased age, growth hormone secretion decreases, and with decrease in calcium, because calcium helps in exocytosis. Exocytosis of growth hormone. Growth hormone is a protein hormone. This is a protein hormone, so it is stored in vesicles, and on getting calcium, it is released. The vacuoles are rupturing on getting calcium. So decreased calcium decreases exocytosis, decreases growth hormone. So what are the diseases that can be caused from increase of growth hormone or decrease of growth hormone? These are the physiological processes. What are the pathological processes? So when there is pathological increase, it is called acromegaly. What are the features of acromegaly? Increased growth of acro. Acro means distal parts, means hand, foot. Okay, so increased growth of these structures. One is hand, foot, that is the terminal bones, facies become coarse, vocal cord becomes thickened, so the voice will be hoarse, and then there will be the glands which will increase in size. So if thyroid increases, Then there will be goiter, plus, that is because of size. Increasing size causes goiter, increasing function of thyroid causes increased BMR. What are the features of increased BMR? There will be tachy, there will be decreased heat tolerance, there will be diarrhea, weight loss, all hyperthyroidism features. Then there will be increase of aldosterone. Aldosterone causes reuptake of sodium and release of potassium and increase reuptake of H2O. So there will be hypertension associated with hypernatremia and hypokalemia. Okay. Then there will be increased. What did it happen? It is responding to hypoglycemia and it is decreasing on hyperglycemia. So what? Growth hormone promotes the release of glucose, increases glucose in the body. So what does it do? Growth hormone increases glucose. So that results in hyperglycemic damage, that results in insulin resistance. Along with insulin resistance, it is not along with, due to insulin resistance, it is going to cause acanthosis nigricans. Okay. Increase in growth of intestinal mucosa. Increase in the growth of intestinal mucosa causes colonic polyposis. Asymmetric growth of left ventricle results in LVH, and LVH is also because of hypertension. LVH and diastolic dysfunction. So there is going to be diastolic dysfunction. More, what is going to hypertrophy? Hypertrophy of synovial membrane, resulting in large joint arthritis. So connective tissue increases, then nerve compression results in carpal tunnel syndrome. Okay, and there is increased hypertrophy of canal of Schlemm. So canal of Schlemm is getting hypertrophied. That is resulting in close angle glaucoma or open angle glaucoma. This is our iris. This is the angle. This is the trabecular network. And through here the drainage occurs. Okay. Only trabecular mesh network blockage can result in open angle glaucoma. All other reasons are causing the angle to shorten. Angle shortens, iris bombi can occur. So this is resulting in angle closure glaucoma. Okay, angle closure glaucoma. So what can be the reasons of acromegaly? One can be GH secreting tumor. It can be of two types, GH plus prolactin secreting tumor or only GH secreting tumor. This is 80% and this is 20%. Another can be GHRH secreting tumor. GHRH secreting tumor, that is GHRH hamartoma of hypothalamus. And another can be paraneoplastic GH release, that can be due to lung, pancreas, lung and pancreas. So these are the causes, these are the clinical features. Okay. So how are we going to, suppose a patient with these features are coming to your OPD. So what will you do to confirm that this is acromegaly? What is the test you are going to do? Now this growth hormone is released pulsatilely. It is a pulsatile release with a T half of 5 to 20 minutes. So if the growth hormone is also more because of the pulsatile release and the short T half, measuring GH is very tactful. Another thing we can measure is this growth hormone converts into IGF-1 in liver. Okay. Insulin like growth factor 1 liver. This has almost the same type of function as the growth hormone, but this is very stable, and measuring this is our screening test. Measuring this is our screening test. Okay, measuring this. The pulsatile release, measuring this is very tactful. It is not impossible to measure this, but it is tactful. So what are we going to do? We know that hyperglycemia decreases growth hormone. So if there is a pathological increase, then hyperglycemia, this is a physiological process, this hyperglycemia is not going to decrease the release of growth hormone. So we are going to give a oral glucose tolerance test. With the oral glucose tolerance test, we are giving 75 gram of glucose, and then we are trying to measure the growth hormone. Now, if we get that growth hormone is less than 1 nanogram, then it is normal. If we get it is more than 1 nanogram, then we know that is acromegaly. And if we get more than 40 nanogram, then it is very bad prognosis. Okay. So another thing we can say that acromegaly can also be precipitated with the increase in TRH. TRH causes increase in growth hormone, in prolactin, and also causes anorexia nervosa. So when can TRH be more? In case of hypothyroidism. So in hypothyroidism, TRH is more, and that can stimulate growth hormone release and prolactin release, causing galactorrhea and causing anorexia nervosa. Okay. Another clinical feature which we can say here, these are the changes happening, and if we go for an X-ray, we will get a shape like this. The phalanges will not be thin. It will not be thin. It will become, the terminal ends will become large. Okay, the terminal ends are going to be large in X-ray. This is known as the arrowhead or spade phalanx. So arrowhead or spade phalanx. Okay, now the treatment. What is the treatment? Firstly, when we are getting this OGTT positive, this is the confirmatory test. We are confirmed that we are having acromegaly. So we now go for a transsphenoidal resection of the tumor. And then after transsphenoidal resection, we measure the post-op GH. Post-op growth hormone estimated. And this post-op growth hormone, if it is present, then if it is negative, we don't have to do anything. If it is present, we go for drugs. First line is surgical. And then if it is still present, then we go for drugs. We can go for somatostatin analogs. Okay. This hyperglycemia mediated decrease is by somatostatin. Okay. Somatostatin analog, that is octreotide. Octreotide. Or GH antagonist, that is our pegvisomant. Pegvisomant. And it can also be done by D2 agonist, that is cabergoline. If still positive, if it is still positive, then we will go for gamma knife radio ablation of the tumor. Okay, so we are dividing the page now. Okay, this is our detection. Okay, this is our diagnosis. This is our treatment. This is our clinical feature. This is our control. This is our cause. So in one page we have completed growth hormone.